Good morning, good afternoon, and good evening. Welcome to Together for Health's second webinar, Expanding Access to HPV Vaccination. Thank you so much for taking time out of your days to join us for this exciting conversation. My name is Petra Stankard, and I'm a technical advisor here at Together. I'll be moderating the webinar today, and we're really looking forward to a fruitful discussion about our progress in HPV vaccination for cervical cancer prevention, including what I think will be a great exploration of some of the challenges and opportunities to accelerate vaccine access on both supply and demand sides. A few logistical notes before we get started. All participants are automatically muted through the webinar. However, I'd like to call your attention to the Q&A icon at the bottom of your screen. If you click on this icon, you can submit your questions using this tool. As moderator, I will track the questions as they are submitted and then direct them to our appropriate speakers. We'll see how time allows, but we'll try to take a few clarifying questions after each speaker and then allow time for about 10 to 15 minutes of more meaty discussion at the end of the webinar. So without further ado, I'd like to introduce our first panelist. I'm pleased to welcome Dr. Anissa Sidibe. She is Senior Program Manager for HPV Vaccine at Gavi. Anissa holds a PhD in Molecular Epidemiology from Imperial College and a Master's in Public Health from the London School of Hygiene and Tropical Medicine. Prior to joining Gavi, Anissa worked in various roles across Africa, including as Head of National Laboratory in the Republic of Congo, Clinical Research Coordinator at the Center for Vaccine Development in Mali, and for the WHO Global TB Program. She has authored several peer-reviewed articles across numerous disease areas. Thank you so much for joining us, Anissa, and I'll turn it over to you to take us forward.
Thank you very much, Petra, for the introductions, and good afternoon, good morning to everyone. Today, I'll present a few slides on Gavi, which stands for the Vaccine Alliance, and about their HPV vaccine program and some of our objectives and aims here at Gavi. Next slide, please. As we all know, cervical cancer is a growing threat. While annual causes of death and maternal deaths have been on the decline since 2015, what we've been seeing is that since 2012, there has been an acceleration and cervical cancer deaths have been on the rise. Today, there's an estimation, a recent estimation that about 416,000 deaths related to cancer by 2035 if no interventions are put in place. And these mostly affect women living with HIV, 4 to 5 times likely to develop cervical cancer. Next slide, please. Even more important, when we look at the map and the distribution or where these cervical cancer deaths occur, what we see is that a lot of them occur in low-income countries and low and middle-income countries. And if you look a little bit more closely at the map that we show, highlighted and dashed with lines going through them are what we call Gavi-supported countries. And we see that a lot of these Gavi-supported countries are also the countries that have the highest deaths due to cervical cancer and carry a heavy disease burden. So we'd like to explain this is one of the reasons why Gavi decided to accelerate this intervention and the vaccine across their countries. Next slide. In order to create a program at Gavi, one of our biggest efforts and accomplishments was really negotiating the price of this vaccine, which back then in 2011, we were able to negotiate a reduction in price for Gavi-eligible countries from $100, which was the price in high-income countries. And I think PAHO countries at the time were getting the vaccine at $13. We were able to get a Gavi price of $4.50. So this is what allowed a window to be open to provide access to this vaccine to low and middle income countries. Next slide, please. A little bit about the program design and the milestones, and I think maybe just a few key highlights to keep into mind. is once we were able to negotiate the price of the vaccine to as low as $4.50, there was still a lot of debates about whether this vaccine could actually be rolled out in low-income countries. At the time, high-income countries were still having some issues around hesitancy, around the effectiveness of the vaccine. So we were not really sure whether also, given the fact that this vaccine would be delivered to adolescents, we were not sure whether the adolescent platform would allow, in our low-income country, would allow a decent coverage for this vaccine, knowing that most of our vaccination programs were really for infants. So we developed what we call demonstration or pilot project, which would target about 15,000 girls. From 2011, you see in the dark green, until 2016, we did really what we called pilot project and demonstration programs, which really targeted only 15,000 girls, just to see whether lessons could be learned and whether this was feasible in our low-income country. And results show that this vaccine was feasible, and we were able to achieve an average of 80% coverage at a low scale. In 2016, we decided to accelerate the program, given the data and the lessons learned that this was possible in our countries. And we decided to accelerate and to move away from pilots and to focus on accelerating national scale up, and with an aim and an objective of targeting 40 million girls by 2020. Next. As part of the acceleration of the new program in 2016, we also decided to provide vaccines and more support to girls 9 to 14 years old, not just one cohort. As before, at the early stages of the program, we were just vaccinating one age between 9 and 14. And this was after the SAGE meeting, which was a WHO policy recommendation body that showed that actually by targeting girls 9 to 14 years old, you could accelerate the benefits, and you can bring forward the benefit by at least 5 years of reducing cervical cancer. And also it provided an economy of scale for delivery strategies in school. So when going to get a girl who's 9 years old in school, you could also pull out other ages, 10, 11, 12, 13, and 14. So given all the benefits around vaccinating 9 to 14, and given sexual debut in a lot of our countries were at 15 years old, and also at ages older than 15 required 3 doses, it just made a lot of sense to target more than one cohort, and actually all girls 9 to 14 in our Gavi countries. So our board approved this strategy and gave us the financial envelope to provide doses to countries to target all girls 9 to 14 years old. Next. However, as you see on this graph, we received, so the new funding window for the Gavi program, the accelerated program, which is targets girls 9 to 14-year-old, was open in January 2017. And as you see on this graph, the demand came really fast from countries. In 2017, we had 13 million doses, just alone from Ethiopia and some other countries. And then that demand kept on rising. And today we're looking at about 57 million doses that we need based on the demand. However, you also see a curve of supply. And what you see here is that until 2022, we're estimated, again, these are really rough figures, but we're estimating that we'll only get about 20 million doses of supply. So this is the biggest challenge and threat to the program. And in terms of the threat of us achieving our goal is really this supply situation, which came and was a little bit of a surprise to us. Next slide, please. So in light of the information that we received from Merck and other manufacturers, at the time we say Merck because that was the preferred dominant manufacturer, we had to put together a mitigation strategy to allow countries to move forward. And that mitigation strategy was to basically separate the multi-age cohort from the routine. So in simple terms, it really meant that we would allow countries to go through and introduce their vaccine with just one single age cohort, And when supply would become available, then do the multi-age cohort. That is all the other age cohorts that were eligible, because we did not have supply to do the originally designed strategy, which would have been really to do all the multi-ages and then go back to only a single age cohort. So this was some of the mitigation strategies that we put in place, which allowed in 2018 4 countries to go through and introduce their multi-age cohort. And now in 2019, we have a lot more countries that are moving forward with this adapted strategy, but as we'll see later, is a little bit less than ideal in our context. Next slide. So today, where we are, as you can see, the HPV program from 2012 to 2016, and it shows national program, as I mentioned earlier, from 2012 to 2016, we don't expect the map to be colored because all we were doing is low-scale programs. But from 2017 to 2019, you start to see the map a little bit more colorful. That is on the right side. And we have today 15 national introductions in pink, and a lot of them you'll see in bracket is written single age. That means they were not able to do the full MAC and only had to go through with a single age cohort. We have 12 other approved programs which are ready to go, and we're still waiting for supply for these countries. And we have 2 other programs that have just applied, and a lot more coming through in 2020. So the supply, again, is really starting to be a challenge into the programs that we had originally established. Next slide. So far, in terms of the introductions that we've seen so far, some of the key lessons learned was that a lot of the countries achieved high coverage by going to schools. This is where the captive audience of girls are. And what we saw is that there was limited experience in reaching out of school girls. Just they focused a lot more on in-school girls. It was a lot easier for them and easier in terms of avoiding dropouts. In terms of integration of school-based delivery strategy, that was a lot more sustainable than doing a campaign mode. When we mean school-based delivery strategy into routine immunization platform, what we mean is the healthcare workers doing outreaches to the community would also consider school as a community spot. So they would go to the schools next to the community, as opposed to doing it intensively into a campaign mode within 2-3 days, just because of the cost associated. We also found that social mobilization was really important for successful uptake, and that EPI program ownership was important, but multi-stakeholders was really critical. So getting involvement of the MOE, cancer societies, community, religious leaders, villagers, and all of the other stakeholders was really important for the acceptance of the vaccine. And finally, some of the countries that tried integration of HPV with other adolescent health interventions found that the cost of delivery was actually a lot lower, and they could achieve a high coverage and allowed better acceptance. For example, deworming, coupling HPV with deworming was one that allowed a higher coverage of HPV. Just acceptance of a package of services to adolescents along with HPV really facilitated uptake. Next. So this is also an example of some of the activities we do on our HPV program, which is around innovation of demand generation. So we have a partnership with Girl Effect, who's really focused on communication and to adolescent girls. And you see here, we have 2 different types of models of communication and doing communication campaigns. One of them is more through illustrations. And the aim here is to design toolkits where you could have different type of illustrations and different kinds of personages that mimic the cultural scope of the country. So if you look at Mauritania, you'll have more Muslim covered like women. You look at Liberia, it's a bit more open. And then we have another type of campaign, which is a photo type of campaign, which Lao use, which is really with mottos such as grow with confidence, showing happy children. So we're really trying to help countries to move away from the normal type of communication of immunization, which are usually just banners, and really make something that's also appealing to the girl herself. As she reads these kind of communication, he feels like demanding the service. So this is a little bit around some of the demand generation aspects that we're trying to bring in, really targeting the girl who can take ownership and actually start having that dialogue with her parents and the caregivers to actually receive this vaccine. Next slide, please. So in terms of going back to the supply situation, in SAGE 2019, just now, last month, the expert group of WHO reconvened to really think about what could be now the adapted immunization schedules and strategies that would allow a higher impact, and allow more countries to introduce, especially in light of the supply constraints, because these supply constraints have been now going on for 3 years. So the matter was taken a bit more seriously to say, is what we've been doing even at Gavi to separate the routine from MAC, is that the way to go forward? Should we be looking at one dose? What should we be looking at to really ensure that a lot more countries can move forward? So that was the aim last month, sorry. Next slide. And some of the considerations that came out of that meeting on a high level was that still, if supply is enough, we should still target the recommended age group, which is 9 to 14. And the ideal dosing schedule still remains a 2-dose with at least a 6 month interval between the 2 doses. That's like the ideal vaccination strategy. And as much as possible, high income countries should try to hold off a little bit on gender neutral vaccination, or targeting older age groups, and even maybe delaying multi-age cohort if there's not enough supply, to ensure that at least at minimum one cohort can go through and can be vaccinated. The other thing that came up was to maybe start with older age cohorts. So when we have an age cohort 9 to 14, you would start with the 14-year-old girls. And these will retain the maximum disease impact and also cap your multi-age cohort such that when there is supply, then you could do 9 to 14 and revert back to 9 years old. So you wouldn't miss any cohort if you started with the older age cohort. And we'll look into that consideration later for Gavi and how this is a little bit difficult for us to translate. The final one that came through with the SAGE is for countries who've introduced but face supply shortage, they can consider a 1+1 schedule, which means they give 1 dose and they would wait 3 to 5 years to administer the second dose. So they would extend the interval between dose 1 and dose 2. So this is a little bit some of the recommendations that were given forward for countries as they think on how to optimize the supply and yet maximize their impact. So starting with older age cohorts, if they were to start with a single age cohort, and maybe doing a 1+1 schedule. Next. In terms of Gavi country, prioritizing the older age cohort is really an issue for us. In the sense that, yes, ideally, these ages would allow us to maximize impact by making sure we don't miss any cohort. But what we found is that in a lot of our countries, 14-year-old girls are already out of primary school. And so the cost of delivery becomes very difficult because either they're out of school or they're in secondary school. And they're really across in urban areas, most could be in secondary school, and in rural area and primary school. So in terms of vaccine delivery, that means countries would have to go across 2 school systems, which is a lot of money. And in terms of 14-year-olds, a lot of them are out of school. So the second dose becomes very difficult. We can catch them for the first dose, but we don't reach a high coverage, which means the herd immunity, we don't reach it with 14 years old. And this strategy of starting with an older age cohort, like some of our countries have seen, 1 or 2, they've started with 14 and they've kept on vaccinating 14 for 2 years because of the supply constraints. And then they have to revert back to 9-year-old after when the supply comes in. So you would do 14, supply comes in, you do a multi-age cohort 9 to 14, and then you would go back to 9-year-old. And switching those ages and communicating around that also confuses the public. So this has really caused a challenge for us in trying to maintain the impact by starting with older age cohort, while still trying to achieve a high coverage and also be mindful of the costs of delivery. Next. And this is just an example, just to see Malawi, which has one of the highest cervical cancer incidence in the world today. They weren't able to do the 9 to 14. And in choosing a single age cohort, what we saw is that the 14 would be impossible for them. As you see here, 20% of 14-year-olds are in primary school, 42% are in secondary, so they would have to do all the primary school in their country and all the secondary school in their country. There's also about 40% out of school girls, whereas if they targeted 9-year-old girl, a lot of them are only 5% are out of school. So their trade-off was, let's achieve a high coverage with 9-year-old, but which also means that with every year of delay of us getting them vaccines, they will lose a cohort. So they will miss bringing the impact forward by 5 years. Yes, they will eventually get to elimination, but it will take 5 years longer than if they were able to do the math. So these are just a little bit of issues that the supply constraint has caused our programmatic design in terms of Gavi's HPV program. But we're working through some of these challenges and with partners and finding the best to really ensure that more countries move forward and in the best way to achieve coverage and be mindful of cost too. Next slide. Thank you. With that, here's a few pictures of some of our introductions in Zimbabwe, Kenya, Tanzania, Solomon Island. So regardless of the issues and the obstacles we face, we've really tried to push forward in terms of the introduction of HPV across the country. Over. Thank you.
Thank you so much, Anissa, for an excellent presentation. Looks like we have one question that maybe we can do just a brief clarification on, and then we'll move on to the next speaker. But we have a question from Shoba. Given some of the supply constraints that you've just outlined, can you share any knowledge we have about when generic versions of the vaccine may be available?
I think we have some good candidates of vaccines, alternative vaccines in the pipeline. And we're looking at maybe 2022, 2023, if they're PQ'd, pre-qualified by WHO. So there are definitely new manufacturers in the pipeline.
Excellent, thank you. I see a couple more questions coming in. That's great. Please continue to submit as they come up. Unfortunately, Anissa needs to leave us for another meeting, but luckily we have a colleague of hers, Arunima, on the line who will stay to answer questions during the Q&A. So we'll have the chance to explore some questions coming out of that great presentation. So thanks again, Anissa.
Thank you, Petra. And I'll just take the question on the school-based program, if it's okay, right before stepping out.
Yeah, sure. Maybe just briefly, that'd be great.
Yeah, sure. I think in terms of research, which would be fruitful for us for school-based program, is really understanding the organizational structure also within an MOH. How do we feel like we've missed opportunities? EPI doesn't generally deliver in schools, and there's a lot of fragmentation in a lot of the countries we've seen on who handles adolescents. Sometimes it's HIV, sometimes it's neglected disease, sometimes it's deworming. So in terms of operational costs, if we could better understand the infrastructure and how we could leverage a joint delivery to really reduce the cost of delivery of HPV and provide better acceptance, that would be very useful. And also how the countries start budgeting a line for school health programs. We found that a lot of them were funded by external donors, and then as soon as the funds were taken out of the country, these school health programs would fall through. So we're really trying to look for a sustainable model that could be leveraged, that could benefit both the country's immunization and broader interventions. Okay.
Excellent. Thank you so much. So as we move forward in our webinar, I'd like to take the opportunity, Anissa has given us an excellent overview of the global issues that the HPV vaccination rollout is facing. And I'm very pleased to introduce Jacqueline Anena, who will speak to us a bit about both some additional information at the global level, but also specifically an experience in Uganda. Jackie is a public health specialist and program officer for vaccines and immunization at PATH, leading efforts to improve HPV coverage and vaccine supply chain and logistics. She's supported the Ugandan Ministry of Health in development of HPV coverage improvement strategies through program coordination, training of health workers and teachers, supervision of coverage improvement activities in both rural and urban areas. She's a recognized immunization and program expert sitting on key technical advisory forums, including EPI Technical Committee and the Vaccine Supply Chain Management Committee. Jackie holds a master's degree in public health and has over 5 years experience in implementing maternal, newborn, and child health programs. She was previously a Global Health Corps Fellow, and before that worked with World Vision in Uganda. So thank you so much. Do continue to submit questions as they arise, and Jackie, I will turn it over to you to take the discussion forward.
Thank you, Petra. I'll be presenting on PATH's HPV vaccine introduction and scale-up in low and middle-income countries with a little bit more detail in Uganda, how we came about to where we are. Next slide, please. So that's my presentation outline. Next slide, please. So you can see that a lot of progress has been made. This map shows the status of HPV vaccine introduction worldwide way back in 2009. And you can see that the highlighted countries in blue had introduced the HPV vaccine at national level. A few other highlighted countries were either demonstrating or had subnationally introduced. Very few countries, or hardly any countries in Africa, South America, as seen on the map. That was 10 years ago. So let's look at the next slide. Here's an updated map. You can see that a lot of progress has been made in these 10 years, and over 50 low middle income countries have introduced HPV vaccine at national level. This number includes World Bank categories of low, lower middle, and upper middle income countries. Next slide. So a multitude of stakeholders at the local, national, regional, and global levels have been involved in these efforts to introduce HPV vaccine, and PATH continues to play a lead role in assisting countries with their HPV program. This map is specifically to PATH HPV support between 2012 and 2019. And currently we are supporting about 10 countries as listed. You can see that we've supported countries for demonstration at national level for the darker shade in blue, and then some countries for the demonstration program only, and then some countries at the national rollout only. Some activities that we do as PATH is to support the planning, implementation, evaluation of the demonstration programs, as well as the planning and implementation at the rollout. Then we have global level activities that we do as listed. We support updates and review of the guidelines. We are advisor to Gavi, advisor to WHO. Next slide. So a little bit more about Uganda. That is a map of Uganda. We have about 135 districts. The number keeps increasing. So currently we have over 40 million people, and current estimates indicate that every year we have over 6,000 women diagnosed with cervical cancer. And of these, over 4,000 deaths are reported. Then the HPV prevalence is at that among women of childbearing age, 18.3%. So for Uganda, in 2007 is when we began the demonstration program targeting girls in primary school, and that was primary form 5 for school, and then community girls who were aged 10 years old. It was in 2 districts, as I'll be elaborating further, and then it phased out, it went in phases. It scaled to a number of districts before the national rollout in 2015. So in 2015, when we rolled out, it was using both the school and community approach for the age-based approach in communities and then class-based approach in schools. Then in 2019, we re-strategized. We changed the strategy from the class-based and age-based for the different community and schools to target purely 10-year-old girls, irrespective of class when they're in school and then in communities as well. All these efforts are in line with achieving the Global Vaccine Action Plan, which is a global framework to end the inequity and extend the benefits of vaccination to everyone. It's a global standard. So these are our targets set globally. We aim that we shall have a minimum of 90% at national coverage and 80% for the district coverage for all our vaccines. Maybe just to mention that Uganda currently we have 9 vaccines in the program targeting 13 vaccine preventable diseases. Next slide. So this is how we started and how far we progressed as a country. In 2007, we started the demonstration project. It continued way to 2012. PATH was playing a lead role in this. And together with Ministry of Health, we implemented this project in 2 districts. Now, each district had a different approach. So one district was targeting girls in school, and these were girls in primary form 5. Then the other district was community girls, aged 10 years. The vaccines were donated by GHK, and we were able to document best practices. We reached over 20,000 girls in this demonstration project. The government became very interested in scaling up this and advised that we continue with the demonstration project, where 12 additional districts were brought on board. At that time, GHK was hoping that the government would procure the vaccines because they had donated vaccines for the demonstration only. But then the government had no commitment to procure vaccines. So there was a lot of back and forth negotiation. And that is when Merck came in and donated the vaccines required for the additional demonstration for the 2 years. And both approaches were used. But then the difference is that at that point, it was targeting primary 4, not primary 5 girls, as previously it was demonstrated in the first time. So in 2015, we rolled out nationally, and we shifted from 3-dose schedule in the first demonstration to 2-dose schedule and using the Merck vaccine. And then the program had tagged HPV vaccination to the Integrated Child Health Days. This is more like a campaign activity where immunization activities are intensified in April and October. And this fitted perfectly with the 2-dose schedule of HPV vaccine 6 months apart. So in 2019, we've re-strategized. We want to improve our 2nd-dose uptake. We had to sit down and change certain things for us to progress. So we changed from the class-based in school to age-based. And then we put a lot of emphasis on the routine uptake, not just limiting it to the other integrated child health program. Next slide. So PATH in Uganda is supporting at national level and subnational level. We do a number of activities at national level, including the implementation of the HPV coverage improvement plan through the training, support supervision, mentorship. We coordinate, we support multi-sectoral coordination among the ministries, and that is the Ministry of Health, Education and Sports, and the local government. These are the ones that head the districts. Then at subnational level, we are providing technical assistance in vaccine delivery and logistics. We support the districts in quarterly reviews and learning meetings, as well as we track their performance. Next slide. So this is how we are progressing. So in 2016, you can see that our second dose uptake was quite low. And over the years, it has remained significantly low, but then we are progressing quite well with the first dose. This is a common challenge among many other African countries, and a few countries have reported success in achieving second dose of over 80%, for example, Rwanda, Mauritius, but then a number of countries are also facing a similar challenge and performing worse than us. But Uganda is making more strides. When we were re-strategizing, when we formed the HPV coverage improvement plan, it was all aimed at improving our second dose uptake. As the former presenter mentioned that there is future potential in single dose for HPV vaccine. Yes, this will reduce a number of costs. For example, it will be easier to implement the program. But then there are certain costs which will always be constant. For example, the startup cost, the ongoing refresher trainings for any vaccines will still be needed regardless of the number of doses that we shall have for any vaccine. Next slide. So over the years, we had lessons that we learned from the demonstration project to the scale up to the rollout, and we've been able to use these lessons to inform our coverage improvement plan. Some of the lessons learned is the partner involvement, the stakeholder coordination, a lot of advocacy, then assessments like the post-introduction evaluation, where we documented a number of things. Then the political will. As I mentioned, in 2012, after 2012, the government was very willing and they owned the project and they mobilized all the resources needed for the 12 additional districts. So political will was very, very key in this. And then adoption of the Reach Every District, Reach Every Child micro-planning is important. And also we have the legal and institutional frameworks like the Immunization Act 2017. All these documents are used and aimed at improving our coverage, and we're using them to improve our coverage. So in 2019, when we started the joint planning and coordination, we conducted national key stakeholder meetings, we identified national supervisors, trained them, deployed them to all districts to conduct support supervision. We mapped every school to a health facility. And then we reviewed the school health guidelines. We have a draft school health policy in place. And then something very important that we had missed out in the first place was including HPV vaccine in the Ministry of Education and Sports M&E framework. Next slide. So these lessons are quite similar to a number of lessons that have been documented globally. And I'll just mention a few because of time. So HPV should be part of the routine. At the point of introduction, we tagged it to the Integrated Child Health Days, but then we learned that it was good for it to be part of the routine. But then for special vaccines that are targeting children outside the immunization age range, the usual immunization age range of under 1, it needs special consideration and patience. Then there is need for proper vaccine forecasting, avoid issues of stockouts. Then also the cold chain assessments were done and they need to be done. For example, for the vaccine we have in the program is a single dose vial, which is a bulk vaccine. So it's very important that we conduct cold chain assessments. Then all these efforts, we need to combine the primary and secondary prevention, messaging, and implementation, which is very, very critical. If we are to eliminate cervical cancer, then we have to bring in the secondary prevention messaging as well. Next slide. And this takes me to the next slide, which I'm going to give an overview of PATS work in screening, preventive treatment, and scale up for adult women. So path, we think we need to go beyond HPV vaccine, as it's very important to address the issues across the lifespan and include the screening and preventive treatment for adult women. We've partnered to develop low-cost, high-quality HPV tests for use in low and middle-income countries. Then we've evaluated these tests in real-world settings. That second picture of two women sitting was taken in Uganda. These are women sitting outside the clinic waiting to be tested. That was during the evaluation. Then we've also partnered with industries to develop new devices for ablative treatment of precancerous lesions of the cervix. And most recently, we've worked with 4 Central American countries to introduce and scale up HPV testing in their public sector medical systems, and where we were able to reach over 250,000 women with screening with HPV testing since 2014. So this brings me to the last slide, where I have shared contacts. In case of any HPV-related questions, I would encourage you to feel free to reach out to me, Manuel, and Scott. Then for our screening efforts, feel free to reach out to Martha and Francesca. Thank you for listening.
Wonderful. Thank you so much, Jackie, for that really fascinating overview of your work in Uganda, and especially also for highlighting the importance of thinking about cervical cancer across the from a life course approach. I think that's a valuable perspective in this broader conversation around vaccination. So I see a few more questions have come in. What we'll do is I'm going to go ahead and move us along so that we can have our final presenter speak, and then leave a bit of time for addressing a few of these questions at the end of the webinar. So with that, I'd like to introduce Jackie Drope, our next speaker. Jackie is Managing Director for Global Cancer Prevention at the American Cancer Society. In this role, she directs programs that support country-led evidence-based interventions to prevent cancer, with a particular focus on tobacco control, healthy eating, active living, and HPV vaccination. These programs focus on strengthening cancer information, education, and communications in low and middle income countries, and influencing the advancement of local policy change for health outcomes. Jackie has a unique mix of experience, having worked in and consulted for various types of health organizations, including the International Union Against Cancer, Ontario Tobacco Research Unit, the World Health Organization, among others. With that, I'll turn it over to you, Jackie, to take us forward. Thank you.
Thanks, Petra, and thanks for everyone for joining the call today, and together for organizing this important webinar. Building on all my colleagues' presentations, I'm going to walk you through some of the efforts of the American Cancer Society's Global Cancer Prevention and Early Detection Programs work. We work both globally and in 4 countries to build demand and uptake for the vaccine, and mobilize communities to ensure all eligible girls are vaccinated. I recognize that building demand seems to contradict the supply reality you've heard earlier, but I do want to add a few other reflections. First, the scale at which we're working presently on demand generation and getting uptake is not a great threat to supply constraints. In many respects, I wish this was our challenge, but the reality is, even in the countries that currently have supply for certain populations, the demand is often not as high as it should be, and we're seeing vaccine hesitancy that's driving numbers down. What we have also learned is that demand takes time to build, so the groundwork we are laying now is critical to prepare for the future supply increases that we hope are coming down the pipe. In fairness, too, it is the role of civil society to ensure we don't lose this momentum around the demand generation piece and the importance of this cancer prevention vaccine. So we need to apply the appropriate pressure to key stakeholders to find solutions to this supply issue. Next slide. I'd like to start with our goal, which I've mentioned is to increase demand and uptake of HPV vaccination, and ultimately to help set our partner countries down the path toward cervical cancer elimination. Next slide. Drawing on our experience that we're building in the US with our HPV cancer-free campaign, our vision is to ensure that health providers are recommending the HPV vaccine routinely and confidently, Parents are demanding their children be vaccinated. Community influencers like teachers and religious leaders are advocating for its access and uptake, and policymakers are ensuring the HPV vaccine is part of a routine national or subnational program. Next slide. Our objectives center around working with local cancer organizations in each country to what we call normalize the HPV vaccination as cancer prevention. And this means, quite simply, framing messaging around cancer prevention and not around prevention of the infection. There are a large variety of actors in the cervical cancer space that are all important, but what we're observing is there's not enough presence of the cancer community in our low and middle income countries. So we've resolved to strengthen cancer organizations so that they can prioritize demand generation and community mobilization of HPV vaccination in their day-to-day work. We also want to ensure that they can actively be involved in mobilizing and leading and coordinating all the different stakeholders that are working in the area. We believe passionately that we, the cancer community, are a key to sustaining this effort and this road to elimination. The stronger the cancer community is in this space, the more likely we will be able to achieve this elimination goal. Next slide. Here you'll see that we have 4 countries we're working in presently: Colombia, Uganda, Kenya, and India. In each country, the HPV vaccination scenario is actually quite unique. In Kenya, our cancer partners have been actively involved in the recent rollout of the vaccine that just happened last week. In Uganda, our cancer partners have been contributing to the coverage improvement plan efforts, including the development of cancer-focused resources. In India, our efforts are focused in one state of West Bengal presently, and since the HPV vaccine is not currently in the National Routine Immunization Plan, efforts are focused on reaching private sector physicians. In Colombia, we're supporting our cancer partner in their efforts to recover from the huge drop in vaccination rates several years back when the media ran with reports that the vaccine was making girls sick. As we know, these concerns were unfounded, but the damage was lasting. Next slide. Here in this slide, you get a quick overview of our approach. As I said, we are working at both the global and country level. Our global work, and you'll see in the white box here, involves managing a global coalition called Cervical Cancer Action for Elimination. This is a new iteration of the former Cervical Cancer Action Coalition you might be familiar with that has been in existence since 2006. This group is a network of like-minded organizations working on cervical cancer prevention who every year pick 1 or 2 goals we know we will be stronger working on together than apart. This past year, we've been putting together a comprehensive website on cervical cancer elimination for advocates so that civil society organizations will have the most current information needed to prepare for and implement local cervical cancer elimination plans. Next year, we're working to create, and we've already started, to create common messages for our organizations to be using one voice in the lead up to the World Health Assembly, where the elimination strategy will be unveiled. Next slide. Oh no, actually, sorry, go back. The other piece here, and the purple piece, and that will lead back up to our LMIC toolkit, is important for this is part of our country work, and I want to explain how our country work. We're working on communications at 3 different levels. First is communications for knowledge, and that ends up being the types of IEC materials that we see in countries that are needed. The second is communications that result in changing behavior, and we'll talk a little bit more about this. And the third is communications for advocacy, and we're doing both the advocacy for policy change and advocacy for budget change. If you look at this, what you'll see is that we do an assessment in country to understand the situation. We work with our local cancer organization, and in the SBCC work, we start with research to understand the facilitators and the barriers to getting girls vaccinated. And once we have that research informs the design and development of interventions. And I just want to stop here and talk about an intervention versus a piece of IEC material. You know, these interventions are aimed at having not just giving knowledge, but having a behavior be changed. So we give an example of reminder systems for physicians to ensure that the girl comes back for a second dose. There's also, we could have tracking systems in schools when teachers are taking girls to get their kids vaccinated. So those are the kind of things that we're working on seeing get developed in country and be appropriate for the local context. As noted earlier, all of our country contexts are quite varied. So what we're doing is we're starting this in each of these countries, and we're going to take the interventions and we're going to look across our countries later and see where there's some similarities and best practices that can be brought together in a toolkit that we can share with other LMIC countries who are also working to increase their vaccination rate. Next slide. It's early days for the country advocacy work I mentioned, and I think someone else, I think it was Anissa, mentioned the need for budgets, and that's going to be a big piece of our work, I think, in supporting. Right now, we're working with our Kenyan colleagues to gain insight into what will be needed at the country level to sustain the HPV vaccine efforts beyond Gavi's support. Next slide. One other thing that we are doing is the development of courses to assist our country cancer partners. One is on cervical cancer prevention fundamentals, and the second on effective communications for HPV vaccination. The first one, the fundamentals course, actually covers cervical cancer, the HPV infection, and the HPV vaccine, as we've noted some confusion in all the areas. More specifically, though, we wanted participants not only to understand these fundamentals, but to feel really comfortable talking on the subject. So that's why we've created this effective communications course to complement it. We've just started piloting these courses, and the first pilot went over very well. But while our intention was to make these courses available to cancer organizations, we already have demand from other communities. So we're considering how best to share more widely through our cancer partners. Next slide. So circling back to our lessons learned from the HPV cancer-free program in the US, a common thread in our work is 4 core messages for HPV vaccination. These messages are that it's cervical cancer prevention, it's safe and effective, it's best given to girls aged 9 to 14, and then in each country we actually adapt that to the actual cohort. So in Kenya last week, it was best given to girls aged 10. And then that is 2 doses or jabs or shots 6 months apart. So yes, our cancer partners adapt these messages to their local context, but yes, there's also room for local partners to create other messages that address local community concerns. We also work in that area as well. But at the end of the day, we believe if these 4 core messages are heard over and over again and retained, we'll be in good shape. So it's our aim now to ensure these key messages are embraced and used consistently across the world. And we need all of you on this webinar and your networks to help make this happen. So stay tuned as we work through the cervical cancer for action for elimination on simple, clear, consistent messages for cervical cancer elimination. That will be beyond these HPV messages and will include screening and treatment, but that we have these kind of core messages that help us all speak with the same voice. Next slide. In closing, I'd like to thank you all for your time and your commitment to this unprecedented opportunity to eliminate the first cancer. Thanks.
Thank you so much, Jackie, for that great presentation, and really exciting to see the engagement of local cancer organizations. As we wrap up, that's the last of our presentations in the webinar. And I see several questions that have additionally come in as Jackie's been speaking. So I'd like to start perhaps by circling back to Jackie and Nana, since we didn't have a chance to take any questions after that presentation. It looks like we have a couple of questions, Jackie, about particularly understanding some of the challenges around the second dose and increasing coverage of the second dose. I think you highlighted that's a challenge in Uganda. Can you speak to some of the constraints that contribute to that lower coverage, as well as some of the successful strategies that have been adopted to address that?
It's a great question, and I have to be honest that right now with our program, we've been really focused on the initial uptake. The research, we're also going to need to do the type of research we're doing in terms of the demand generation and uptake, and now also move that to understanding why we're losing people with the second dose. But we did decide very consciously to start with the uptake piece.
Great, thanks for that perspective. And maybe also to Jackie, to you as Jackie Anena as well. What about from the Uganda experience?
So from Uganda experience, there's been a lot of laxity in the second dose follow-up, and also among the teachers there is information gap, and yet these teachers are very significant players. So when you look at ineffective follow-up, there's high dropout because of the human resource capacity gap at the health facilities. They may need to be reminded, and that is why we are mapping every school to a health facility, and then the teachers have been brought on board so that when there are girls who are due for their second dose, the teachers should also take the mandate to remind the health workers that you are scheduled to come to our school on such and such a date, we are expecting you. So that kind of collaboration between the schools and the health facilities to mitigate some of the human resource capacity gaps. And then there's also a lot of complaints on insufficient funds to manage outreaches. For example, the immunization outreaches is funded under the primary health care fund, which is not sufficient, but it comes back to planning. How do the health workers plan for these outreaches? And that is why a lot of health workers were riding on the integrated child health days. That's when they would go to the schools. But then the numbers would be overwhelming. And then you're not sure if you're able to vaccinate all the girls in a single day. You'll leave out some girls, or the vaccines may run out. So emphasizing the routine uptake of this HPV vaccine is one way of addressing this. Another key barrier has been the anti-vaccination groups on social media recently. And that is why it is very important as a country to have a legal framework in place. We have the Immunization Act, which mandates every child to be vaccinated. There's nothing like parent consent here. So when the country is able to enforce such laws, there's significant difference. So these are some of the actions that we've taken as a country towards improving immunization.
Thank you for that. And maybe to follow up on your last point and to address one of the questions that has come in, this question is directed to Jackie Drope, and particularly the reference to the advocacy campaigns that you discussed during your presentation. How have you thought about measuring the impact of those campaigns? And I know you mentioned they're early stages. Have you thought about measuring impacts around those?
Yes, certainly. Well, and I think it really will depend what the advocacy campaign is. We'll see the impact if, for example, it's getting it in routine immunization into a national plan. Then ultimately the final outcome, if we haven't gotten that, is that it hasn't worked. And when we're looking at budgets, same thing. I mean, I think that we can measure whether or not we're seeing subnational or national governments prioritizing the vaccine in their budgeting. So, you know, I think that's exactly how we'll monitor to make sure that what these advocacy campaigns are resulting in the outcomes we're seeking.
Great. Excellent. And maybe just to circle back on one question that was asked, and I realize we're at the top of the hour, but one last question that was asked following Anissa's presentation, Arunima, if you're still on the line, and I think this speaks also to what both Jackie Drope and Jackie and Nana have flagged, is a question about specifically some of the work that's been done to address vaccine resistance for vaccinating school-age girls. Can you talk to, from Gavi's perspective, about some of the approaches that you've seen tried as you support rollout?
So thanks. So of course, in lieu with what Jackie and both Jackies have just highlighted, for Gavi, as Anissa mentioned, social mobilization and engagement of the multiple stakeholders who kind of influence the society and the perceptions of the society in terms of what vaccination is, etc., is extremely crucial. So we ensure that when we are developing social media and social mobilization and communication plans, all of these stakeholders are touched upon. So you don't just sensitize the healthcare workers, but also the teachers, and ensure that the teachers also sensitize the parents on the other hand, as well as religious leaders, community leaders, village leaders, everybody who is part of the decision making and influence for HPV vaccination in low and middle income countries. Additionally, because we do foresee, a lot of vaccine hesitancy and a lot of rumors that might break right before the introduction, we had certain rumors that also came about in Kenya recently. What we always tell countries is to have a crisis communication plan alongside their communication plan, and also a crisis committee that kind of monitors these kinds of rumors, etc. Because I think one of the speakers also mentioned that social media has now become is a boon, but also a curse when it comes to anti-vaxxers. So these are certain things that we always make sure are kind of covered. So social mobilization and communication is extremely crucial, and also having a crisis communication plan in place. Over.
Great, thank you for that. So that brings us to the top of the hour. I realize there are a few more questions. Unfortunately, we won't have time to address all of them, but we will make this webinar recording available online on our website, and you'll receive a link to that recording in a follow-up email. The contact information for speakers, I believe, was included within all of their slides, so we encourage you to follow up. And certainly, we hope that this is one of many conversations that we're able to have around HPV vaccination, and that really we've started, I think we've only scratched the surface and started the conversation today. So we certainly at Together and with our, as well as with our partners, really look forward to continuing the conversation. So thank you so much for joining today. And please do keep a lookout for information regarding our next webinar, which will be focused on the integration of cervical cancer prevention services within family planning service provision. So that will be coming up in November, and we will be circulating information about that webinar shortly. Thank you so much, and have a wonderful rest of your day.